neural structures such as different nerve trunks like sympathetic trunks, vagus nerves and phrenic nerve, and lymph nodes are there. Okay, so here you can see the structures along on the two sides of the vertebral body. This is sympathetic chain, splanchnic nerves. These are the agitus vein draining into the superior vena cava, two brachiocephalic veins joining to form the superior vena cava. This is phrenic nerve. This is vagus nerve. This is view from the right side. So here you can see the right phrenic, right vagus. This is lung root. Okay, and this is esophagus. In front of esophagus, here is the trachea. This is heart enclosed within the pericardium, and this is diaphragm, and this is view from the left side. Here you are getting, this is anterior aspect. Here you can see the sternum. These are the vertebral bodies. Here lies the sympathetic chain, and contents you can see the heart covered with the pericardium. Here is the lung root, and over the lung root, arching structure. This is arch of aorta. Here is descending thoracic aorta. Posterior to the lung root, this yellow colored nerve is the left vagus. And anterior to the lung root, here is the left phrenic nerve. And here you can see the esophagus. In front of esophagus, here is trachea. And this small structure, this is thoracic duct. This is one lymphatic structure. Okay, and some lymph nodes you will also see, mediastinal lymph nodes. So the divisions, for the purpose of description and organization of structures, mediastinum is artificially divided into two parts. It is not actually divided parts in our body. Okay, for description we are dividing it. Superior mediastinum and the inferior mediastinum by an imaginary plane. This plane is known as transverse thoracic plane, passing through the sternal angle anteriorly. Here is the sternal angle, junction between the manubrium and body of the sternum. So transverse thoracic plane is dividing the mediastinum into superior and inferior mediastinum, and it is passing anteriorly through the sternal angle anteriorly and the lower border of body of fourth thoracic vertebra and intervertebral disc between T4 and T5 vertebra posteriorly. Here, this line, see, this is T1, T2, T3, T4. So lower border of T4, imaginary line passing through sternal angle anteriorly and lower border of T4 posteriorly. Okay, so this part above this plane is superior mediastinum and the part below it is the inferior mediastinum. Here is the transverse thoracic plane. So this part is superior mediastinum. Here is the inferior mediastinum. Okay. Next, the inferior mediastinum is further subdivided into three parts by the pericardium enclosing the heart. See, this is pericardium enclosing the heart. It is dividing the inferior mediastinum into three parts. Anterior to it lies the anterior mediastinum, posterior to it is the posterior mediastinum, and the heart and the pericardium included within the middle mediastinum. So these are the three divisions of the inferior mediastinum. Okay. So anterior mediastinum, the part in front of the pericardium; posterior mediastinum, the part behind the pericardium; middle mediastinum, the pericardium and its contents, that is heart and root of its great vessels. Okay. So this is the division of mediastinum. Mediastinum divided into superior and inferior. Inferior is again divided into three parts: anterior mediastinum, middle mediastinum and posterior mediastinum. Okay, so division is clear. Next we will discuss individual mediastinum and their contents. First, the superior mediastinum. Its boundaries are, see, this part is superior mediastinum, bounded anteriorly by the manubrium sterni, posteriorly by bodies of T1 to T4 vertebra, on each side by the mediastinal pleura. Superiorly lies the plane of thoracic inlet, inferiorly imaginary line joining the sternal angle and lower border of T4 or transverse thoracic plane here. So superior mediastinum. Okay. Now the contents of the superior mediastinum. See, this dotted line is representing the transverse thoracic plane. So the structures lying above, these are the contents of the superior mediastinum. Okay. So see the contents. Three muscles are there: sternohyoid, sternothyroid. These two are attached on the posterior aspect of manubrium sternum. Longus coli. Longus coli is attached to the vertebral body posteriorly. Thymus, this is present only in childhood and puberty. Veins. Veins are the superior vena cava, right and left brachiocephalic veins and left superior intercostal vein. See here, right and left brachiocephalic vein, these two are joined to form the superior vena cava and these are located in the superior mediastinum. And left superior intercostal vein, on the left side, first, second and third intercostal vein join to form the left superior intercostal vein. This is small vein, sometimes you can see during the dissection. Okay. So arteries are arch of aorta and its three branches: brachiocephalic trunk, left common carotid, left subclavian artery. See here, this is arch of aorta, ascending aorta forming the arch, then continuing downward as the descending thoracic aorta. Okay. Arch of aorta beginning at T4 vertebral level and also ending at T4 vertebral level, beginning anteriorly and ending posteriorly. And its three branches you can see from right to left. These are the brachiocephalic trunk, left common carotid and left subclavian. Okay. And this brachiocephalic trunk on the right side, it is dividing into right common carotid and right subclavian. Okay, understood? So this arch of aorta and its three branches are included within the superior mediastinum. Other things are trachea and esophagus. Here this structure you can see with cartilage. This is trachea and it is dividing into two principal bronchi downward. Esophagus lies posterior to the trachea. Nerves are the vagus, phrenic, cardiac, left recurrent laryngeal nerve between trachea and esophagus. Okay. See here, these are the vagus nerves. Phrenic nerve is lying anterior to the lung root, and at the tracheo-esophageal groove lies this left recurrent laryngeal nerve. Okay. It is hooking around the undersurface of this arch of aorta. See, this is a branch from this left vagus. Left vagus giving a branch, left recurrent laryngeal, which is hooking under the undersurface of this arch of aorta, then ascending upward between the tracheo-esophageal groove. Okay, understood? Next structure is thoracic duct. Thoracic duct we have seen in previous picture, and lymph nodes are present. Brachiocephalic and tracheobronchial lymph nodes are present here in the mediastinum. See here, this is thymus gland. Okay, lying anteriorly. Different structures has been shown here. See, this is two brachiocephalic vein, right and left, and this is left superior intercostal vein which is draining into left brachiocephalic vein. These two brachiocephalic vein is joining to form the superior vena cava. Here you can see the arch of aorta and its three branches: brachiocephalic trunk, left common carotid, left subclavian. Here is the trachea, this is esophagus, this is right vagus, this is left vagus. You can see from the left vagus, this branch is known as left recurrent laryngeal nerve, hooking on the undersurface of this arch of aorta and then ascending upward at the tracheoesophageal groove. Okay. And here this is sagittal section through the thorax. You can see the sternum, then posterior to sternum, here lies the thymus gland, not present in adult. It is replaced by fatty tissue in adult. Heart and pericardium, ascending aorta, arch of aorta, descending aorta. This is left pulmonary artery, part of lung root. This is left principal bronchi. Here is the esophagus, trachea. Okay, this is inferior vena cava draining into the heart. Okay, left atrium, right atrium. Okay, so these structures you will see. Okay, so contents of the superior mediastinum from anterior to posterior, you can remember like this: mind, thymus, larynx, baton. You can remember like the mnemonic. Muscles are the sternothyroid, sternohyoid. I is internal thoracic artery. It is lying in the anterior chest wall. Thymus gland is present. L is for lymphatics, lymphatic vessels. Thoracic duct and lymph nodes are present. Veins are the upper part of superior vena cava, left and right brachiocephalic vein, left superior intercostal vein. Arteries are arch of aorta and its three branches: brachiocephalic trunk, left common carotid, left subclavian. T is trachea with paratracheal and tracheobronchial lymph nodes. O is esophagus. N is for nerves. Nerves are the phrenic, vagus, cardiac nerves, left recurrent laryngeal nerve in the tracheoesophageal group. Okay, so these are the contents of the superior mediastinum. This is a transverse section through the superior mediastinum showing the arrangement of the contents. See, this is section through the sternum, manubrium sternum. Posterior, on its posterior aspect, these two muscles are attached: sternothyroid, sternohyoid. Then you can see the thymus. These are the veins, left and right brachiocephalic vein. These are the three branches of the aorta. On the right side brachiocephalic trunk, left common carotid, left subclavian. See, these are the nerves, right and left phrenic nerve. These are the vagus nerve, right and left vagus nerve. From the vagus nerve, this left recurrent laryngeal nerve is lying in the tracheoesophageal groove, in between the trachea and esophagus. Trachea has C-shaped cartilage, and posteriorly the two ends of the cartilage is joined by the trachealis muscle. Okay, this is, and the cartilage is absent posteriorly for helping the distension of the esophagus during intake of food. And this is longus colli muscle attached over the vertebral body. On the two sides of the vertebral body, two sympathetic chains are present. Okay, and here is the vertebral canal. Spinal cord will lie here, and these are the processes of the vertebra. This is spinous process, and these two are the transverse process. And these are the, on the two sides, mediastinal pleura, pleural cavity, and lungs. Okay, and this is thoracic duct, section of, this is part of lymphatic tissue. Thoracic duct you cannot see very clearly, very fine structure. Rest of the thing you can see. Okay. So you practice a schematic diagram like this: section through the superior mediastinum. Next we go to the anterior mediastinum. So superior mediastinum, its boundaries and contents we have covered. Next we go to inferior mediastinum. It has three divisions: anterior, middle and posterior. So anterior mediastinum boundaries: anterior boundary by the sternum, body of the sternum; posterior boundary formed by the pericardium, and on each sides there is mediastinal pleura, and superiorly there is imaginary plane. This is imaginary plane, it is forming superior boundary, and inferior boundary is formed by the diaphragm. Contents of the superior mediastinum: thymus gland in children, which is replaced by fatty tissues in adults; sternopericardial ligaments. Okay, this is connecting the sternum with the pericardium. Okay, so there are two sternopericardial ligaments, superior and inferior sternopericardial ligaments. There is internal thoracic artery and its branches. Its branches are the pericardioacophrenic and musculophrenic. It is dividing into two branches. Lymphatics and lymph nodes. All these are contents of the anterior mediastinum. See here the contents of anterior mediastinum has been shown. See, this is thymus gland. Here thymus gland has been shown. These are the two sternopericardial ligaments connecting the pericardium with the sternum. Okay, and another thing is lymphatics, an internal thoracic artery lying in the anterior chest wall. Next we go to middle mediastinum. This heart and its pericardium, this are included within the middle mediastinum. So it boundary anteriorly bounded by anterior mediastinum, posteriorly bounded by posterior mediastinum, superiorly bounded by superior mediastinum, and inferiorly there is the diaphragm. Okay, so this is the boundary of middle mediastinum. What are the content of middle mediastinum? Heart enclosed in the pericardium. Arteries are the ascending aorta, pulmonary trunk with its right and left branches. Veins are the superior vena cava, termination of azygous vein, pulmonary veins. These are the veins. Nerves are the phrenic nerve, deep cardiac plexus in front of bifurcation of the trachea. And tubes are the bifurcation of trachea with two principal bronchi, and lymph nodes are the tracheobronchial lymph nodes. So all these are content of the middle mediastinum. You can see here heart enclosed within pericardium, ascending aorta, pulmonary trunks, its right and left divisions, azygous vein draining into superior vena cava, 4 pulmonary veins. Okay, and here you can see the arch of azygous vein arching over the right bronchus, arch of aorta arching over the left bronchi, and below the arch you can see this recurrent laryngeal ascending in the tracheoesophageal groove. This is thoracic duct. Okay, and this trachea and esophagus, this muscular tube is esophagus. These are included in posterior mediastinum, and these are the lymph nodes, tracheobronchial lymph nodes. Next we go to the posterior mediastinum. See, this green colored portion is the posterior mediastinum, posterior to the heart. So boundaries, anterior boundary is formed by the pericardium and its contents. Bifurcation of the trachea and pulmonary vessels. These are the anterior boundary. Posterior boundary is formed by bodies of T5 to T12 vertebra and intervening intervertebral disc. Superior boundary by transverse thoracic plane and inferior boundary by the diaphragm. And on each side laterally there is mediastinal dura. So this is the boundary of the posterior mediastinum. Now what are the contents of posterior mediastinum? Contents are esophagus. See, this is muscular tube, this is esophagus. Arteries are the কি হলো ঘুম পাচ্ছে সবার? Okay, so contents are the esophagus. Arteries are descending thoracic aorta. See, arch of aorta is downward from the level of T4 as the descending thoracic aorta and along with its branches. The posterior intercostal arteries are branched from this descending thoracic aorta. Next are the veins. Veins are the 3 veins are there. Azygous vein on the right side and hemiazygous and accessory hemiazygous present on the left side. Okay. Nerves are the vagus nerve, sympathetic trunks and splanchnic nerves, thoracic duct and lymph nodes. Lymph nodes are the posterior mediastinal lymph nodes. So these are the content of the posterior mediastinum. see the contents. Here the heart with pericardium has been removed to show the structure in the posterior mediastinum. You can see the esophagus, the muscular tube is the esophagus, trachea dividing into two bronchi. Here is the descending thoracic aorta, azygous vein, thoracic duct, vagus nerve and sympathetic trunk. All these are contents of the posterior mediastinum. Here you can see descending thoracic aorta. Here is the muscular tube will be the esophagus. See here, this muscular tube is esophagus. This is trachea, descending thoracic aorta, left vagus, left recurrent laryngeal. Okay. Here also you can see esophagus, descending thoracic aorta, and see here azygous vein is present on the right side and accessory hemiazygous above and hemiazygous vein is below, present on the left side. These two are crossing at T7 and T8 level to join the azygous vein on the right side. Okay. So posterior intercostal veins are draining on the right side into this azygous vein, and on the left side they are draining into the accessory hemiazygous above and hemiazygous vein below. Okay, understood? This is thoracic duct. This is starting below from the cisterna chyli, ascending upward and draining at the left brachiocephalic vein. Okay, two veins, left internal jugular, left subclavian is joining to form the left brachiocephalic vein. Okay, understood? And this is sympathetic chain. Splanchnic nerves. This is phrenic nerve lying in front of the lung root. This part is the lung root. And this is superior vena cava. And you can see these veins. These are the posterior intercostal veins draining into the, this is left side because you can see the descending thoracic aorta. So here is presence of accessory hemiazygous above and hemiazygous vein below. Okay, and they will cross at T7, T8 level to drain into the azygous vein on the right side. Okay, so clinical aspect regarding mediastinum. So mediastinum can come as a short note, individual mediastinums. So if individually they can come, you can write down the boundaries and contents and schematic diagrams, whichever you practice. Okay, so clinical aspect is mediastinitis from infections of neck pass under the prevertebral fossa. The deep fossa of the neck have three layers. Okay, investing layer of deep cervical fossa, prevertebral layer and pretracheal layer. See here, this is prevertebral layer which is attached at the level of T4. This is pretracheal layer lying in front of trachea, and this is investing layer of deep cervical fossa. So from infection of neck pass under the prevertebral fossa reach till T4 only, not beyond it, as prevertebral fossa is attached here. So if the pus is formed from the vertebra, like in tuberculosis of the vertebra, spinal TB, so pus is extending up to T4 level because here the prevertebral layer is attached. And pass between the pretracheal and prevertebral layer, it seeps through the superior mediastinum to reach the posterior mediastinum. There is, it can freely pass here and in front of pretracheal fossa to the anterior mediastinum. If it lies, the pus can pass in front of pretracheal layer of the fossa, it enters into anterior mediastinum. And psoas sheath communicates with the posterior mediastinum. Psoas sheath, psoas major is a muscle in the posterior wall of the abdomen. Okay, so in front of the psoas, so it is covered by deep fossal covering that is known as psoas sheath. So this psoas sheath communicates with the posterior mediastinum by a funnel shaped orifice. Therefore, pus from the posterior mediastinum can easily enter the psoas sheath and track down into the thigh in the region of femoral triangle. Okay, so from the neck, pars can extend through the posterior mediastinum, through the psoas sheath up to the thigh region. Okay, so this is a lateral view X-ray. Okay, so this is transverse thoracic plane. Above it, this is superior mediastinum. Here is anterior mediastinum. This is posterior mediastinum. And you can see here the hard shadow. This is lying with the middle mediastinum. And this is dome-shaped structure is the diaphragm. Okay, and this is frontal gas shadow of the stomach. Next is mediastinal syndrome. Compression of the mediastinal structures by any growth such as tumor or cyst will lead to mediastinal syndrome. Common causes are bronchogenic carcinoma, aneurysm of aorta, enlargement of mediastinal lymph nodes in Hodgkin's disease. Clinical feature: engorgement of the veins in the upper half of the body due to obstruction of superior vena cava. Dyspnea, that due to compression of trachea. Dysphagia due to compression of esophagus. Hoarseness of voice due to compression of left recurrent laryngeal nerve. Left recurrent laryngeal nerve is supplying the vocal cords, which is responsible for formation of voice. Okay, so if it is paralyzed, one vocal cord will be paralyzed, so there will be hoarseness of voice. Erosion of bodies of thoracic vertebra due to pressure on the vertebral column. So these will be the clinical features of mediastinal syndrome. Mediastinal syndrome can come as a short note. Okay, mediastinal syndrome. Next is mediastinal widening. It is caused by hemorrhage. This is important for your medicines also. In your final year medicine, these causes are asked very frequently in your X-rays or in clinics. So what are the causes of mediastinal widening, causes of mediastinal shifts? You have to see palpate the trachea, whether it is shifted to right or left, and then you will be asked the causes of shift. So mediastinal widening causes a hemorrhage in the mediastinum from lacerated vessels following trauma. Example, head-on collision. Massive enlargement of the mediastinal lymph nodes due to cancer of the lymphatic tissue, namely malignant lymphoma. These are the causes of mediastinal widening. An enlargement or hypertrophy of the heart due to congestive cardiac failure, if it is commonest cause of enlargement of the inferior mediastinum. Next is mediastinal shift. It is common in lung and pleural pathology, can be detected by palpating the trachea in the suprasternal notch. Here you have to palpate the trachea, okay, in the suprasternal notch. When it is shifted to the disease side and when it is shifted to the healthy side. It is shifted to the diseased or affected side due to an appreciable reduction in the lung volume and decrease in intrapleural pressure, as in collapse of the lung or atelectasis. Okay, if lung collapse occurred, then this trachea will shift to the disease side and shift to the healthy side due to intrapleural pressure is appreciably high on the affected side, as in pneumothorax or hydrothorax. Okay, see here pneumothorax has been shown. Okay, there is breach in the pleural cavity, air is entering from outside into the pleural cavity. Okay, so intrapleural pressure is high and this is leading to collapse of the lung and it is pushing the trachea to the healthy side. On this side the lung is healthy. Okay, so this is shift to the healthy side, occurs in pneumothorax or hydrothorax. Next is subcutaneous emphysema of the root of the neck. In esophageal perforations caused by penetrating wounds, air escapes into the connective tissue spaces of the mediastinum and may ascend beneath the fossa to the root of the neck, producing the subcutaneous emphysema. Next is potential dead space in the superior mediastinum. All the large veins superior, this is important, this counts as explain why question. Okay, so potential dead space in the superior mediastinum, all the large veins, superior vena cava, right and left brachiocephalic veins, they are on the right side, and all the large arteries, arch of aorta and its 3 branches are in the left side. So during increased blood flow, large veins expand enormously while the large arteries do not expand at all. And this is because there is sufficient dead space on the right side, and it is into this space that tumors of the mediastinum tend to project. Okay. So tumors of the mediastinum tend to project towards the right side because right sides there are spaces for expansion of these veins. It cannot extend to the left side because there are large arteries are present and arteries are not that much compressible. Okay. So that's why any tumor in the mediastinum tend to project towards the right side. This comes as a explain why question. Why any tumor of mediastinum tend to project towards the right side.
থাকুন, চোখ রাখুন, ফিরছি অল্পক্ষণের মধ্যে। আপনারা দেখছেন বিকাশ টক্স।
আপনারা দেখছেন পজিটিভ বার্তা প্ল্যাটফর্ম। থিঙ্ক পজিটিভ, বি পজিটিভ।
New Delhi, June 14. In a proud moment for social impact, Positive Barta has been officially honored by the Asia Book of Records under the rare category, largest social empowerment initiative across multiple platforms by an individual. The recognition ceremony held at the Press Club of India celebrated not just an initiative but a movement, a voice that has reached far and wide, carrying stories of hope, empowerment, and change. Dignitaries from across India graced the occasion, including officials from the Rashtrapati Bhavan, Ministry of Home Affairs, senior journalists, doctors, lawyers, defense officers, and chain makers from diverse walks of life. Dr. Shweta Jha of Asia Book of Records handed over the award to Positive Barta's founder and CEO Sri Malaipit, declaring the concept as unprecedented in the Asia Pacific region. A recognition not just for scale but for uniqueness. To mark this moment, our national awareness program titled Positive Barta, a movement of positivity and empowerment was also held, unifying educators, healthcare leaders, women entrepreneurs, and civil society members under the mission. In a world clouded by negativity, Positive Barta dares to tell a different story, one that uplifts, empowers, and inspires from the grassroots. Receiving the award, Malaipit said, "The best stories are still unfinished. This is not just an award. It's a reminder when purpose drives action, records follow." He thanked his team and left the audience with a powerful message. Carry one positive story home today. One story can change a life. Imagine what millions can do.
Very good afternoon everyone. I am Dr. Shweta Jha. I am pleased to introduce myself as the official representative from Asia Book of Records. I am here today to announce the results for the record called largest multi-platform social empowerment initiative by an individual. Asia Book of Records is a platform where the record holders of all major national book of records, including India Book of Records, Vietnam Book of Records, Indo-China Book of Records, Laos Book of Records, and Nepal Book of Records, meet to compare, compete, and claim the title of Asia Book of Records. Hold. Today, Asia Book of Records holds a strong database of 40,000 entries. Now it's time to announce the record for Asia Book of Records, largest multi-platform social empowerment initiative by an individual. The record for the largest multi-platform social empowerment initiative by an individual was set by Malay Pit from Purva Vardhaman, West Bengal, India, for launching Positive Varta, a multi-channel initiative promoting positivity, education, healthcare, and empowerment across mobile apps, social media, TV, and community programs. His work impacts diverse sectors including women entrepreneurship, tribal upliftment, and youth development, fostering inclusive growth and social transformation as confirmed on June 14, 2025. We extend our heartfelt congratulations to Malay Pit for setting the Book of Records through his visionary project Positive Varta. He has created a far-reaching impact across education, healthcare, women entrepreneurship, tribal upliftment, and youth development by harnessing the power of mobile apps, social media, television, and grassroots programs. Malay Pit has become a true catalyst for inclusive growth and social transformation. His dedication to building a more empowered and positive society is truly commendable. Congratulations once again.
सर इधर देखना है सबको, इस कैमरे की तरफ, पीछे वाले को जरा बोलिए, इनको इधर दिखाओ। हाँ सर इधर देखिए, इधर यही वाला कैमरा है बस। हाँ बाकी सब ये नीचे वाला मोबाइल बाकी सब। सर इधर देखना। सर इधर देखिए।
पॉजिटिव वार्ता ने एक इतिहास बन दिया। पॉजिटिव वार्ता का एशिया बुक ऑफ रिकॉर्ड का नाम एक हिस्ट्रिकल मोमेंट है। इसके लिए बहुत अच्छा है क्योंकि एक ऐसा प्लेटफॉर्म जो सोशल डेवलपमेंट करने के लिए काम कर रहा है, जिससे आप सब जुड़े हुए हैं और आगे जाके पॉजिटिव वार्ता और भी बड़ा होगा, ये हम लोग आशा करते हैं। धन्यवाद सभी को जुड़ने के लिए। जल्द हाथ करिए। आज पॉजिटिव वार्ता का एशिया बुक ऑफ रिकॉर्ड का अवार्ड मिल रहा है। ये सिर्फ हम लोगों के लिए नहीं, पूरे भारतवर्ष के लिए गर्व की बात है।
और सबके लिए ये मेरा टीम है, ये सारा इंडिया से यहाँ पर आया। आप या सोचेंगे लेकिन इम्प्लीमेंट सबके लिए थिंक पॉजिटिव, बी पॉजिटिव, पॉजिटिव। इंडस्ट्री के लिए, शिक्षा के लिए, शास्त्र के लिए और डेवलपमेंट के लिए पॉजिटिव होना चाहिए। पहले पॉजिटिव, बाद में सब कुछ डेवलप होगा। इसलिए शिक्षा तो वो जरूरी है, लेकिन सबसे जरूरी पॉजिटिव थिंकिंग। इसलिए मैं बोलता हूँ और जो यूट्यूबर और जो सोशल मीडिया फ्रेंड सोसाइटी के लिए जरूरी है पॉजिटिव स्प्रेड के लिए। ये सोसाइटी का ड्यूटी है, हर व्यक्ति का ड्यूटी है कि पॉजिटिव थी स्प्रेड के लिए। इंडस्ट्री आगे बढ़ेंगे, सब कुछ आगे बढ़ेंगे। पहले सोचेंगे मेरे पॉजिटिव होंगे और पॉजिटिव होंगे। धन्यवाद।
Your mental health is our priority. মানসিক চাপ, একাকিত্ব, ভয় এসব আর লুকিয়ে রাখবেন না। শান্তিনিকেতন মেডিকেল কলেজ ও হাসপাতালে শুরু হচ্ছে সাইকোলজিক্যাল কাউন্সেলিং। বিশিষ্ট সাইকোলজিক্যাল কাউন্সিলর মৌ ভট্টাচার্যের তত্ত্বাবধানে প্রতি বৃহস্পতি, শুক্র আর শনিবার। টক টু সামওয়ান হু লিসন, আন্ডারস্ট্যান্ড, কেয়ার্স। এটা আপনার জায়গা, নিরাপদ, নিঃশব্দ, নির্ভরযোগ্য। বিকজ হিলিং বিগিনস উইথ ওয়ান কনভারসেশন। শুরু করুন নিজের মনের দিকে একটা ছোট্ট কদম। মেন্টাল হেলথ ইজ স্ট্রেংথ অ্যান্ড ইউ আর নট অ্যালোন। আপনার ভবিষ্যৎ নিয়ে চিন্তিত, কনফিউজড অ্যাবাউট হোয়াট টু ডু আফটার ক্লাস 12? এখন সময় এসেছে বেছে নেওয়ার এক সুরক্ষিত এবং চাহিদা সম্পন্ন ক্যারিয়ার, ফার্মাসি। ভর্তি চলছে শান্তিনিকেতন ফার্মাসি কলেজে। Approved by PCI, affiliated to WBSCT and VESD. এখানে আপনি পাবেন ডাইরেক্ট অ্যাডমিশনের সুযোগ। DPharm 2 years ডিপ্লোমা কোর্সে। যোগ্যতা খুব সহজ, 10+2 সায়েন্স স্ট্রিম থেকে PCB বা PCM। কিন্তু ফার্মাসি কেন? কারণ ফার্মাসি পেশার ভবিষ্যৎ অত্যন্ত উজ্জ্বল। বিশ্বজুড়ে হেলথ সেক্টর ক্রমাগত বাড়ছে, চাহিদা বাড়ছে স্কিলড ফার্মাসিস্টদের। আপনি কাজ করতে পারেন এখানে গভর্নমেন্ট বা প্রাইভেট হসপিটালে, ফার্মা ম্যানুফ্যাকচারিং কোম্পানিতে, ড্রাগ রিসার্চে, বা খুলে নিতে পারেন নিজের ফার্মাসি স্টোর। বিশ্বের সাথে তাল মিলিয়ে ডিজিটাল ফার্মাসি এবং টেলিমেডিসিনের ক্ষেত্রেও তৈরি হচ্ছে নতুন সুযোগ। তাই বলছি, এটাই সময় ভবিষ্যৎকে সুনিশ্চিত করার। রয়েছে স্কলারশিপের সুবিধা, মেধাবী ছাত্রছাত্রীদের জন্য গভর্নমেন্ট পলিসি অনুসারে। কিন্তু মনে রাখবেন, হারি আপ, সিটস আর লিমিটেড অনলি। অ্যাডমিশন চলছে 2025-26 শিক্ষাবর্ষের জন্য। কলেজের ঠিকানাটা নোট ডাউন করুন: গোবিন্দপুর, মুলুক, বোলপুর, বীরভূম 731204 এবং এখনই কল করুন 7479001943 নাম্বারে। আপনারা ইমেলের মাধ্যমে যোগাযোগ করতে পারেন শান্তিনিকেতন ফার্মাসি কলেজ @gmail.com। আপনারা কলেজের ওয়েবসাইট ভিজিট করুন www.spcpharma.in। শান্তিনিকেতন ফার্মাসি কলেজ, ফার্মাসি পড়ুন, গড়ুন নিরাপদ ও গর্বিত ক্যারিয়ার। শান্তিনিকেতন সেবানিকেতন নার্সিং ইনস্টিটিউট। এই প্রতিষ্ঠান শুধু নার্স তৈরি করে না, তৈরি করে একজন জীবনযোদ্ধা, যারা হাসি মুখে ব্যথা ভাগ করে নেয় আর মমতায় ছুঁয়ে দেয় হাজার হাজার মানুষের প্রাণ। The institute approved by Indian Nursing Council and affiliated to WBNC and WBUHS. Two noble paths await you here. BSc Nursing, 4 years of learning, caring and growing. GNM Nursing, 3 years of hands-on skills and heartfelt service. এই 3 কিংবা 4 বছরের পথ চলা শুধু একটা ডিগ্রি অর্জনের গল্প নয়, এটা একজন মানুষ থেকে একজন পরিপূর্ণ নার্স হয়ে ওঠার এক অবিচল যাত্রা। Here you don't just sit in classrooms, you walk the real corridors of care from private hospitals to government facilities. And yes, even in the institution's own hospital where practice becomes perfection. Student credit card opens doors that once seemed closed. সবাই তো পারে না স্বপ্নের পথে নির্ভয়ে হাঁটতে, কিন্তু এখানে প্রতিটা ছাত্রীর পাশে দাঁড়ায় প্রতিষ্ঠান নিজেই, যাতে টাকার অভাবে কোনো মেয়ে স্বপ্নের সিঁড়ি থেকে পিছলে পড়ে না পড়ে। তুমি যদি সত্যিই মানুষকে ভালোবাসো, যদি চাও দুঃখের মুখে হাসি ফোটাতে, তাহলে শান্তিনিকেতন সেবানিকেতন নার্সিং ইনস্টিটিউট তোমার জন্য অপেক্ষা করছে। এর হাত ধরে জয় করো তোমার স্বপ্ন।
নমস্কার, আমি দীপান্বিতা পাল। আমি স্বাধীন নার্সিং ইনস্টিটিউটে কর্মরতা একজন ক্লিনিক্যাল ইনস্ট্রাক্টর। আমি কিভাবে নার্সিং পড়ে এই প্রফেশনটি চুজ করলাম সেই বিষয়টি আজকে আপনাদের সামনে তুলে ধরব। প্রথমেই বলি, আমি এইচএস কমপ্লিট করি 2020-তে। আমার এইচএসে কতগুলি সাবজেক্ট ছিল যেগুলি সায়েন্স ব্যাকগ্রাউন্ড থেকে, যেমন ফিজিক্স, কেমিস্ট্রি অ্যান্ড বায়োলজি। ছোট থেকে আমার ইচ্ছে ছিল সমাজসেবী হওয়ার। তার জন্য আমি ভেবেছিলাম আমি মেডিকেল দেব, কিন্তু আমার ফিনান্সিয়াল কন্ডিশনের জন্য মেডিকেল পড়ার জন্য যে পরীক্ষাটি দিতে হয়, যেটি নিট, সেই পরীক্ষাটি আমি ঠিকঠাকভাবে দিতে পারি না, এবং যার জন্য আমি তারপর চুজ করি নার্সিং প্রফেশনটিকে। তার জন্য আমি জেনপাস ইউজি পরীক্ষাটি দিই। তারপর আমি বিএসসি নার্সিং কোর্সটি কমপ্লিট করি এবং আমি স্বাধীন নার্সিং ইনস্টিটিউটে 3 মাস হলো ক্লিনিক্যাল ইনস্ট্রাক্টর হিসেবে জয়েন করেছি। আমাদের এই কলেজে মূলত দুটি কোর্স পড়ানো হয়, জিএনএম নার্সিং যেটি 3 বছরের এবং বিএসসি নার্সিং যেটি 4 বছরের কোর্স। বিএসসি নার্সিং পড়ার জন্য সায়েন্স ব্যাকগ্রাউন্ড থেকে হতে হবে এবং অবশ্যই ফিজিক্স, কেমিস্ট্রি, বায়োলজি অ্যান্ড ইংলিশে 45% অ্যাবাভ মার্কস থাকতে হবে, এবং জিএনএম নার্সিং পড়ার জন্য আর্টস ব্যাকগ্রাউন্ড থেকে হলেই হবে এবং ইংলিশে অবশ্যই 45%-এর অ্যাবাভ মার্কস থাকতে হবে। আমাদের কলেজে রয়েছে উন্নত ল্যাব ফেসিলিটি এবং লাইব্রেরির সুবিধা। এছাড়াও রয়েছে কোর্স কমপ্লিট করার পর আমাদের নিজস্ব হসপিটাল, যেটি 1100 বেডেড হসপিটাল, শান্তিনিকেতন মেডিকেল কলেজ অ্যান্ড হসপিটালে 100% প্লেসমেন্টের সুবিধা। আমাদের কলেজে ভর্তি প্রক্রিয়া শুরু হয়ে গেছে। বিস্তারিত জানতে যোগাযোগ করুন স্ক্রিনে মেনশন করা নাম্বারটিতে। নাম্বারটি হলো 9083298435। নমস্কার।
অত্যন্ত আনন্দের সঙ্গে জানাই, পশ্চিমবঙ্গের অন্তর্গত পূর্ব বর্ধমান জেলার গুসকরার সন্নিকটে আমাদের শেফালি মেমোরিয়াল প্রাইভেট আইটিআই। বর্তমানে আমাদের কলেজে সিট বুকিং চলছে 3টে ট্রেডের উপর: ইলেকট্রিশিয়ান, ফিটার এবং ওয়েল্ডার। ইলেকট্রিশিয়ান যা 2 বছরের কোর্স, মাধ্যমিক পাস। ফিটার 2 বছরের, মাধ্যমিক পাস, এবং ওয়েল্ডার 1 বছরের কোর্স। তাই অযথা দেরি না করে আমাদের কলেজে আসুন এবং সিট বুকিং করুন। 25-26 সেশনের অ্যাডমিশন চলছে। এই কলেজে, অর্থাৎ আমাদের শেফালি মেমোরিয়াল প্রাইভেট আইটিআই কলেজে যে সমস্ত পরিকাঠামো, অর্থাৎ উন্নত মানের লাইব্রেরি পরিষেবা, উন্নত মানের আইটি ল্যাব, এর সাথে আমাদের মেটাভার্সের মাধ্যমে, উন্নত টেকনোলজির মাধ্যমে আমাদের ছাত্রছাত্রীদের পঠন পাঠন হয়ে থাকে। তাই আমি আরেকবার বলি, আপনারা আমাদের কলেজে আসুন এবং সিট বুকিং করার জন্য এবং ভিজিট করার জন্য আমাদের আমন্ত্রণ রইল আমাদের এই কলেজ ক্যাম্পাসে। তার সাথে আরেকটা কথা বলে রাখি, যেটা হচ্ছে যে বর্তমানে যে জবের ব্যাপার, আমাদের কলেজ ক্যাম্পাসের পক্ষ থেকে বিভিন্ন কোম্পানির মাধ্যমে জব হয়ে থাকে এবং প্রতি বছর ছেলেমেয়েরা কোম্পানির কাজে যায়। তাই আমি পরিশেষে বলবো, এই কারিগরি শিক্ষার মাধ্যমে বেকারত্ব থেকে মুক্ত পেতে আপনারা আসুন আমাদের সেফুল মেমোরিয়াল প্রাইভেট হাইস্কুল। ধন্যবাদ, ভালো থাকুন।
আপনারা দেখছেন পজিটিভ বার্তা চ্যানেল। থিঙ্ক পজিটিভ, বি পজিটিভ।
Discover medicine in your language. Join the journey of knowledge with Chikitsa Pathshala, a special initiative focused on medical education in multiple languages, tailored for every aspiring minds. Tune in daily from 10 a.m. to 2 p.m. and again from 10 p.m. to 6 a.m. only on Positive Barta. Experience in-depth learning, expert insights and simplified explanations, all in the language you are most comfortable with. Positive Barta, where learning meets opportunity. Stay tuned, stay informed, step into the future of medicine with us. আপনারা দেখছেন পজিটিভ বার্তা প্ল্যাটফর্ম। থিঙ্ক পজিটিভ, বি পজিটিভ।
So ribs, classification of ribs, it is classified according to its articulation with the sternum as true ribs and false ribs. Okay, true ribs are vertebro-sternal ribs. Their anterior ends articulate directly with the sternum through the costal cartilages, and examples are 1st to 7th pairs of ribs. And false ribs, their anterior ends do not directly articulate with sternum, and examples are 8th to 12th pairs of ribs. Okay, these are false ribs. These false ribs are again of two types, vertebrochondral ribs and floating or only vertebral ribs. Vertebrochondral ribs, this classification is very important. It is important for your viva. In bone stable axial skeleton, there will be vertebra and ribs and cranial bones. Okay, so for bone stable viva, this classification is very important. Classification of ribs. So vertebrochondral ribs, costal cartilages join with costal cartilage of the next higher costal cartilage. Examples are the 8th, 9th and 10th pairs of ribs. And floating or vertebral ribs, here anterior ends are free. Examples are the 11th and 12th pairs of ribs. Next, according to the morphological features, we are dividing the ribs into typical ribs and atypical ribs. Typical ribs are 3rd to 9th pairs of ribs, and they have same general features. And atypical ribs are the 1st, 2nd, 10th and 12th ribs, 10, 11, 12. Okay, they have different features than the remaining ribs, different than these typical ribs. So this is the classification. We are dividing the ribs into true ribs, false ribs. True ribs are vertebro-sternal ribs, 1st to 7th. False ribs are again of two types, vertebrochondral and floating ribs. Vertebrochondral are 8th, 9th and 10th rib, and floating ribs are vertebral ribs, 11th and 12th rib. Ribs are again divided into typical and atypical. Typical ribs are 3rd to 9th ribs. Atypical are 1st, 2nd and 10, 11, 12 ribs. Okay. Okay, so what are the features of typical ribs? You have to know it first so that you can see the difference with the atypical ribs. So typical ribs have common general features. Examples are 3rd to 9th ribs. How will you hold it in anatomical position? Hold the rib in such a way that anterior end has a concave depression. See, this is the anterior end. It articulates with this costal cartilage. So here is a depression. Anterior end has concave depression and posterior end has globular head. Here is the globular head. Okay, so shaft is flat and convex outward. This is the shaft. Costal groove and shaft inferior border lie downward. This is the costal groove and shaft border is lying inferiorly. Convexity of the shaft is directed towards the side of the rib. Okay. So this convexity is directed to this side, that is right side. So this is a typical rib of right side. Okay. So and tilt of the rib is tilted. This head end is slightly above than this anterior end. Okay. So tilt the rib. So posterior end lies at higher level than the anterior lip. So this will be the anatomical position of the typical ribs. Now we go to the atypical ribs. What are the difference among them? First rib, second rib, 10th, 11th and 12th ribs are the atypical rib. First rib is shortest rib. Its head contains single facet. Neck is present. Tubercle has no non-articular part. Only a small articular part is present. Costal groove is absent. Angle coincide with the tubercle. And ossification centers, one primary center for the shaft is present here in first rib. And secondary center, one for the head, one for the tubercle. For second rib, it is head contains two facets, neck is present, tubercle has small non-articular part. Costal groove is small, ossification center, one primary center for shaft is present, and secondary center, one for the head, two for the tubercles. 10th rib, head contains single facet, neck is present, tubercle present, costal groove is present. All of these almost similar to the typical rib, except head contains this single facet. Okay. And ossification center, one primary center for shaft is present, secondary center, one for head, two for tubercles. Here in first rib, only one for the tubercle, one for articular part. Here only articular part is present. Next we go to 11th rib. Here also single facet. Here neck is absent, tubercle is absent. Costal groove is faint, angle is also faint. And ossification center, one primary center for the shaft is present and one for the head. No tubercle, so no center for tubercle. Okay. Next we go to 12th rib. It is the smaller rib. Head has single facet. Neck, tubercle, costal groove, angle, all is absent in 12th rib. Okay. And ossification center, one primary center for the shaft is present and one secondary center for the head is present. Okay. So these are the ossification centers. So we will discuss individual ribs in details. First rib is very important. Its identification features, attachments are important. Okay. So first rib, identification features. It is shortest, broadest and most curved rib. Shaft is flat and has superior and inferior surfaces and inner and outer borders. Head has only one small facet. Tubercle has only articular facet, no non-articular area. There is no costal groove. Anterior end is very broad and thick. Upper surface shows two grooves separated by a scalene tubercle. Okay. See, this is first rib. It is the shortest and stoutest rib. There is the head, neck, tubercle, only articular area is present. This is upper surface and below will be the lower surface. Here is the inner border and this is the outer border. And this is scalene tubercle. On two sides of the tubercle, two grooves are present. Anterior groove is for subclavian vein. Posterior groove contains the subclavian artery and lower trunk of the brachial plexus. Okay. And this scalene tubercle, it provides attachment to scaleneus anterior muscle. Okay. So how will you hold it in anatomical position? Hold the bone in such a way that upper surface with two grooves facing upward and forward, making an angle of 45 degrees with the horizontal plane. And rounded head lies posteriorly and broad anterior end lies anteriorly at lower level than the posterior end. Convex outer border faces towards lateral side of bone. And how will you decide the side? You place the first rib on a flat surface. Okay. If the two ends are touching the ground, then it is side is correct. Okay. So if you keep the first rib on table in correct position, both ends will touch the table. And if wrongly placed, you can turn it opposite side. It will not touch the table. Okay. So see here, this is first rib and this is typical rib. You have to place this costal groove below and sharp border is below. Convex surface towards the lateral side. This is anterior end. Here is posterior end containing two facets for the head, neck, and here is the tubercle. Tubercle has articular part and non-articular part here. Okay, smooth part is articular and rough part is non-articular. So this will be the position of the typical rib. Anterior end is lower than the posterior end. Now for first rib, it is more tilted than the typical rib. If you place it on a flat surface, if I place it like this, two ends are touching the floor. Okay, so this is a first rib of this left side. Okay, and hold it with the same hand to which side it belongs. Head will be above, anterior end will be downward, and the flat surface of the rib will form an angle of 45 degree with the horizontal plane. So this will be the anatomical position of the first rib. And along the inner border, here is one scalene tubercle, and in front of it, this groove is for the subclavian vein, and posterior to it, this groove is for the subclavian artery and lower trunk of the brachial plexus. Okay, and in front of this neck of the rib, there some structures are related, I will discuss. And this is the tubercle. Tubercle has only articular part. Okay, and head is globular. So this is a first rib of left side. Okay, understood? So you will be able to hold it in anatomical position. You place the rib on a flat surface. When the two ends are touching the ground, so the rib belongs to that side. So this is first rib or anatomical position of first rib of left side. Okay. So this is first rib. It has an anterior end. It is broad and thick. Forms the first costochondral joint. This is primary cartilaginous joint. This type of joints are important. Okay. First costochondral joint is primary cartilaginous joint. Posterior end shows head, neck, and tubercle. Head is small and rounded, has single articular facet, articulates with body of first thoracic vertebra. Neck is rounded and elongated. So this is neck. Next we go to posterior end. Relations. Anteriorly, the neck of first rib is related from medial to lateral. Here, on the anterior surface of the neck, from medial to lateral lies this sympathetic chain, first posterior intercostal vein, superior intercostal artery, ventral ramus of the first thoracic nerve. Okay, so you can remember like this. Sympathy provides superior vision, or you can make your own mnemonic. Okay, sympathetic chain, then the vein, first posterior intercostal vein, then superior intercostal artery, and ventral ramus of first thoracic nerve. This is very frequently asked in your viva. Relations of neck of the first rib. Okay, understood? Next we go to the tubercle. Here is the tubercle. Tubercle is large, coincides with posterior angle of the rib. Rib has two angles. Here the sharp bend is occurring posteriorly. This is posterior angle. And here in this region where bend is occurring, this is anterior angle. So tubercle is lying at the posterior angle. In typical rib, tubercle is lying proximal to the angle. Okay. So in first rib it coincides with the angle. So tubercle is large, coincides with posterior angle of rib, has only articular part, articulates with transverse process of first thoracic vertebra, and lateral costotransverse ligament is attached to the tubercle. Okay. Next we go to the shaft. Shaft, its relations we will discuss. Shaft is flat from above downward, has superior and inferior surfaces, and outer and inner border. This is outer border, this is inner border. Superior surface has two shallow grooves separated by scalene tubercle lies near the inner border. Here is the scalene tubercle where scalenus anterior is attaching. And these are the two grooves, anterior groove containing subclavian vein, posterior groove is containing subclavian artery and lower trunk of the brachial plexus. Now go to the attachments. Scalenus medius inserts on the elongated rough area behind the groove for subclavian artery up to the tubercle. So this is the insertion of scalenus medius. Scalenus anterior inserts on scalene tubercle. Here is the scalenus anterior. And subclavius originates from the lateral part of the anterior end. Here, subclavius muscle is originating from the first costochondral junction, at the junction between the anterior end and costal cartilage of first rib. Okay, understood? Next is one ligament is present. Costoclavicular ligament extends from medial part of anterior end to the medial end of the clavicle. Here, costoclavicular ligament, medial part of anterior end to the medial end of the clavicle. Inferior surface, so we have discussed, completed the superior surface. Next we go to the inferior surface. It is smooth and does not have any costal groove. Relations, it is related to costal pleura. An attachment, it gives origin to internal intercostal and intercostalis intimus muscle. These two intercostal muscles are attached over the inferior surface. Okay. Next we go to outer border. Outer border is convex outward. Attachments are external intercostal muscle and first digitation of serratus anterior. Here is first digitation of serratus anterior and external intercostal whole of the outer border. First digitations of serratus anterior originate from outer border just behind the groove for subclavian artery. This is groove for subclavian artery, just behind this groove it is originating. Next we go to inner border. This is inner border. It is concave inward and shows scalene tubercle along superior surface. Here is the scalene tubercle. Attachment is suprapleural membrane or Simpson's fossa. Okay, this is very frequently asked. What is suprapleural membrane or Simpson's fossa? It is attached along the inner border of the first rib. Okay, it is covering the apex of the lung, Simpson or suprapleural membrane. Understood? Okay, so to summarize the first rib, it is the shortest, broadest and flat rib. Ends, it has anterior end is broad, posterior end contains head, have single facet, neck is rounded, tubercle has only articular facet. Surfaces has upper surface and lower surface. Upper surface, anterior groove for subclavian vein, posterior groove for subclavian artery. Subclavian tubercle provides attachment to scalenus medius, okay, posterior to the groove for subclavian artery, and scalenus anterior attached to the scalene tubercle, and subclavius muscle originating from first costochondral junction. Lower surface smooth, no costal groove. Borders, outer convex border gives attachment to external intercostal, and serratus anterior first digitation takes origin from outer border. Inner border is concave, provides attachment to suprapleural membrane. Okay, understood? So it is flat from above downwards, first rib. Okay, so we have completed the first rib. Next we go to second rib. Second rib, its length is twice that of the first rib. Here is the second rib. Okay. Shaft is sharply curved but not twisted. Head is small, carries two facets. This is head carrying two facets. Tubercle has non-articular part is small. This is tubercle have both the parts, articular and non-articular, but non-articular part is small. Shaft middle of outer surface has typical large rough tubercle that gives attachment to serratus anterior. Here, this rough area gives attachment to serratus anterior. Outer surface faces upward and outward. Okay. What are the features? Inner surface faces downward and inward. Short costal groove on posterior part of inner surface is present. Scalenus posterior and serratus posterior superior insert on the upper border on the posterior part here. Scalenus posterior and serratus posterior superior attached over here, inserted over here. Okay. Okay, so you see the second rib. See, this is second rib of left side. Convex surface is facing upward and laterally. Concave surface is facing downward and medially. Okay, and in the posterior part, small costal groove is present. Here is the tubercle having two parts, both articular and non-articular, and head containing two facets. Okay, and it is almost twice the length of the first rib. And this is rough area where serratus anterior muscle is attached and other two muscles are attached over here. Okay, understood? So this will be the anatomical position of the second rib. Always for rib, anterior end is lower than the posterior end. Okay, and this posterior end is placed more medially than this anterior end, because along the anterior end there is attachment of costal cartilage. So it will keep the anterior end away from the midline. So this will be the anatomical position of the second rib. Understood? Okay, next we go to the 10th rib. Okay, 10th rib. This is second rib actually. So 10th rib, head has single articular facet, articulates with 10th thoracic vertebra, and length is shorter than the typical rib. Only difference is this, you remember this point to identify 10th rib. Head has only single articular facet, articulates with the 10th thoracic vertebra. Okay, understood? Next we go to 11th rib. What are the identification features? Head has single large articular facet, neck is absent, tubercle is absent, anterior end is pointed, angle is faintly marked angle on the outer surface is present. 12th rib, identification features: head has single facet, anterior end is pointed, neck, tubercle, angle, costal groove all are absent in 12th rib. Okay. Okay, 12 ribs have multiple attachment. We will discuss it. Okay. So see here, how will you hold it in anatomical position? Okay. So this is 11th rib. You place it like this. Concave surface is above. Okay. Convex surface is laterally and downward, and anterior end is directed laterally. There is no costal cartilage attachment. Only tip is covered by a very thin layer of cartilage. Okay, and head has only single facet. Okay, so this is 11th rib. 11th and 12th difference is only in the length. Okay, 12th is smaller in size. 11th is lengthier. This is 12th rib. This is also, it is 11th rib of left side. So you will hold it like this. Posterior end is higher than the anterior end, and anterior end is directed laterally. Concave surface is above, convex surface is downward and laterally. Okay, so this is 11th rib of left side. So to understand the anatomical position, yes or no? Okay. Next we go to the 12th rib. Here also head contains a single facet for articulation with body of 12 thoracic vertebra. Here also concave surface is looking upward and tip is not articulating and it is floating and directed laterally. Okay, and all the other features of typical ribs are absent. No neck, no tubercle, no costal groove, no angle. Okay. Okay, now we go to the attachments of 12th rib. So side determination and anatomical position hold the bone in such a way that pointed end is directed forward and laterally, sharp border is directed inferiorly, concave inner surface is directed inward and slightly upward. Okay, concave inner surface is directed inward and slightly upward, and convex outer surface faces side of the bone and will determine side to which the bone belongs. Okay, convex outer surface faces towards the side of the bone. Okay. These are the attachments and relations of the 12th rib. This is we are viewing from the inner surface, and this is on the outer surface, viewing from the outer surface. So you see the attachments, latissimus outer surface. Okay, so this is outer surface. You can see the attachments here. Here is attachment of latissimus dorsi, external oblique, serratus posterior inferior, longissimus thoracis, erector spinae, levator costae. Okay, and these are the attachment of costotransverse ligament, and here is lumbocostal ligament. So these are the attachment of this outer surface, and also there is attachment of middle layer of the thoracolumbar fossa. So latissimus dorsi muscle originates from upper part of area near the tip of the rib. Here, upper part of the area near the tip of the rib. External oblique originates from lower part of the area near the tip of the rib. Erector spinae and levator costae insert on the medial half of outer surface. Okay, erector spinae and levator costae, medial half of the outer surface. Serratus posterior inferior insert in lateral half of outer surface. Here is serratus posterior inferior. Okay. Next we go to the inner surface. This is inner surface. Here is attachment of quadratus lumborum. Here is internal intercostal muscle. Here is diaphragm, lateral arcuate ligament, posterior layer, middle layer and anterior layer of the thoracolumbar fossa. All the three layers are attached in this inner surface. Okay. Thoracolumbar fossa has three layers. So inner surface, quadratus lumborum, here is quadratus lumborum, inserts on the lower part of medial half of inner surface. Internal intercostal muscle insert near the upper border. Here, internal intercostal. Diaphragm originates from anterior end of inner surface. Here is attachment of the diaphragm. Upper border, external intercostal inserts and internal intercostal originates from the upper border. Here insertion of internal intercostal has been shown. Next, along the lower border, these ligaments are attached. Lumbocostal ligament extends from head of 12th rib to the transverse process of L1 vertebra. Lumbo means lumbar attached with the costal facet. Okay. Ribs are developing from costal element. That's why the name is given. Lumbocostal ligament. Here is the attachment of lumbocostal ligament. Extends from head of 12th rib to transverse process of L1 vertebra. Next is lateral arcuate ligament. Extends from middle part of lower border to tip of the transverse process of L1 vertebra. Okay, almost nearly in this region. Attachment of lateral arcuate ligament. Middle layer of thoracolumbar fossa. Here is attachment of middle layer of the thoracolumbar fossa. Important relations. Inner surface is related to costodiaphragmatic recess of the pleura. Okay. Oblique line on the middle part of inner surface marks line of pleural reflection. Okay. So this rib is related to the costodiaphragmatic recess of pleura. In hydrothorax or pneumothorax, pyothorax like this, you have to insert the needle into this costodiaphragmatic recess to drain the fluid. Okay, fluid or air. So this is enlarged view of different attachments. Next we go to the clinical aspect. First is cervical rib. Cervical rib comes as a short note. Okay, cervical rib, important clinical aspect. Lies at the root of the neck. See here, generally ribs are starting in the thoracic region from T1 to T12. Okay, but if in the cervical region, generally in the 7th cervical vertebra, if one rib is present, that is known as cervical rib. So it lies at the root of the neck. Incidence is found in about 0.5 to 2% of individuals. Embryological basis, elongated costal element of C7 vertebra may be unilateral or bilateral, may have three pointed tip, or its tip may be fused with first rib. Okay. Effects, it may compress lower trunk of brachial plexus and subclavian artery. What are the symptoms? There will be pain along the medial side of the forearm and hand, wasting of the intrinsic muscles of the hand. So these are the symptoms of cervical rib. Next clinical aspect is rib fractures. What are the common sites of fracture? Angle of the rib is weakest area of the rib. Okay, there is sharp bend near the angle. So this is most commonest site of fracture. And if fracture occurs, which structures will be damaged? Fracture rib may damage the pleura, lungs, liver, spleen, diaphragm, and so on. All these structures can be damaged in rib fracture. Lumbar rib, also called gorilla rib, develops from costal element of L1 vertebra. Okay, there is no such symptoms like the cervical rib. Cervical rib is important because it may compress over important vessels and nerves like this. That's why there will be symptoms in cervical rib. Next is flail chest. In case of multiple fractures of a rib, segments of rib moves freely and paradoxically moves inside during inspiration and outward during expiration. This segment is called flail segment, and it should be treated surgically with plates or wires. Okay. Rib excision, access thoracic structures in surgeries such as pulmonectomy. In removal of the lungs, there may be required of rib excision. Okay. Now we go to the ossification of ribs. For typical rib, all the typical ribs, 3rd to 9th and 10th rib, ossify from one primary center. For the sap, and appears at 8th week of intrauterine life. And 3 secondary centers appear at puberty as follows: one for the head, one for articular part of tubercle, and one for non-articular part of the tubercle. These are the 3 secondary centers for typical ribs. And secondary centers fuse with the rest of the bone between 28th to 25th years of age. First rib has only one secondary center for tubercle because it has only articular part. That is the difference from typical rib. And 11th and 12th rib has only primary center for sap and one secondary center for the head. It does not have any tubercle, that's why no center for tubercle, only head. For head, one center is present. Okay, so this is ossification of rib. So you have to know the identification points. First rib is very, very important. Okay, and others you just know the difference from typical ribs. And you will be able to hold it in anatomical position. I am showing you again. So first rib, for first rib you place it on a flat surface. If the two ends are touching the floor, it is in correct position. So if you place wrongly, head will be not touching the ground. Okay. So it is a first rib of left side. And on the upper surface you can see the grooves for subclavian vein, subclavian artery and scalene tubercle at the inner border. Okay, so it has upper surface, lower surface, inner border, outer border, anterior end, posterior end, head, neck and one tubercle containing only articular part. So this will be anatomical position of first rib. And this anterior end is more lateral than the posterior end, and the plane of the rib is forming an angle of 45 degree with the horizontal plane. So this will be anatomical position of first rib. Next we go to the second rib. Here it is convex surface is directed upward and laterally, concave surface is directed downward and medially. And there is a small costal groove in the posterior part. It has an anterior end, posterior end. Posterior end is containing the head, containing two facets, neck and tubercle. Tubercle has both parts, articular and non-articular. Okay, and here is a rough area for serratus anterior. So this is the anatomical position of second rib. Anterior end is lower than the posterior end. Anterior end is more lateral than the posterior end. Okay, understood? So this is second rib of left side. Next we go to the 11th rib. 11th rib you place it like this. One single facet. 10th